It's a very touchy subject for sure. There are a few select patients that are on board and even a few that ask for it to be tapered, and those are obviously the most exciting ones. You're like, yes, this is gonna be easy. I think, we always talk about the pendulum. Now it's getting to kind of a point where lots of people are thinking that everyone needs to be tapered off of opioids, and that isn't necessarily true. I'm seeing patients, being referred to me to be tapered, and they're a volunteer firefighter, and they rescue people with the jaws of life. They go to church, they garden. They have all sorts of things that demonstrate that they're functional, and they're not really on a high dose, don't have many comorbidities or concerns with other medications that they're mixed with, no aberrant behavior. Is that there's lots of patients who are benefiting from opioid medications and being tapered or being told to be tapered off of medications where it's not necessarily appropriate. So I do, in those circumstances, recommend against opioid tapering, but there are lots of situations in which patients really shouldn't be on these medications anymore. They're not helping them, or the risks. Ultimately, like I said, it comes down to the risks outweighing the benefits. So when that happens, then we have to make a change in our plan.
Most patients are familiar with the climate change in pain management and how the pendulum has kind of swung to the opioid phobia side. So 2 years ago, when I was questioning if this is really what I wanted to do, and it was very stressful, and the patients were really, really challenging in that this was those are the first people you're working through this concept with, whereas now 2 years later a lot of them are much more familiar with it, or the education has kind of percolated through primary care, pain management, surgery, the emergency room, all these different areas. So we're not the first people kind of introducing this idea to them. They're still not all of them are 100% receptive, but I think they're much more understanding at this point, which makes our job a little bit easier because the foundation's kind of already been laid.
I do everything I can to be empathetic and do what's best for the patient, but obviously not everyone's going to be happy with what we have to say, even though I am thinking their best interests. And they're even, I have, upset and frustrated patients and who aren't happy with going through a taper. But I've also seen the other side of things when we come out at the other side. And some people, aren't very happy or frustrated, but as we taper off of medications, they are able to think more clearly. I've had patients who are more functional when we have tapered their opioids, or I've even gotten people off of opioid medications and got them into medication-assisted therapy for opioid use disorder, and have seen them have improvements in their life being on that treatment. Seeing a patient, go on buprenorphine, and now they're going to their grandkids' baseball games. So it is very challenging. Should everyone be tapered off of opioids? No. Is everyone happy to go under taper? No, but we do see some good come out of that.
And I think that last point kind of hits the nail on the head. Like, we try to emphasize to the patient that every patient case is treated differently or uniquely. We're not like a cookie cutter model. We're not, there is this magical number that the guidelines say everyone should be at, but that's not necessarily going to be the case for everybody. So we do try to make sure they understand that throughout this process. We're really trying to individualize their regimen, whatever that might end up being at the end, to their specific needs and what works best for them.